Welcome back to Neuroblastoma Parent Global Symposium 2023. My name is Mary Claire Rennick of Childhood Cancer Ireland, and I'll be moderating this session entitled Psychosocial Cancer Toolbox. And this session is going to be delivered by the following people. Firstly, you will have a session by Joanna Hunt, who is Specialist Occupational Therapist at Sheffield Children's NHS Trust, United Kingdom. That session will be followed by a joint session with Dr. Natalie Jakubowski, who is Pediatric Palliative Care and Hospice Physician and Psychiatrist at Nationwide Children's Hospital, USA, and by Dr. Andrea Wojtowicz, who is Pediatric Psychologist also at Nationwide Children's Hospital, USA. Their session is going to be then followed by Dr. Megan Marzak, who is Associate Director of the Center for Pediatric Traumatic Stress, University of Kentucky Healthcare, USA, followed by Dr. Hilary Van Horn-Gatlin, who is a clinical psychologist and Director of Organizational and Leadership Development in the Permanente Medical Group, USA. The final session is going to be delivered by Dr. Maureen Brennan, who is Senior Clinical Psychologist at Childhood Cancer Ireland. And before I hand over to the first speaker, I'd just like to draw your attention to the chat function, which will be on the right of your screen. And you can submit questions throughout all of the sessions. You can also submit them anonymously or with your name, whatever you choose. And the questions will then be addressed at the end of the session to the relevant presenters or generally. So now over to you, Joanna, to present your session on Spoony Kids Fatigue Project.
Fab, thanks ever so much. Hello, everybody. It's a pleasure to be here. Thanks ever so much. My name's Jo, as we've just learned, and today is about Spoony Kids. Spoony Kids draws on spoon theory, which uses spoons as a metaphor for an amount of energy that can be saved or spent. Next slide, please. On different tasks. And it was inspired whilst working within an acute oncology setting with an 8-year-old going through treatment at that time for a neuroblastoma, and co-produced with children, young people and families with lived experience. So the overall aim of today's session is to create a space that allows opportunity to further develop understanding of the nature of fatigue, to support the child at the centre to live their best life, but also importantly to help manage both individually but also as a family. So the key points as shown on this slide will be covered in my presentation today. And this approach is now being used in over 20 NHS trusts across the UK and internationally, both within acquired brain injury and oncology settings, amongst others, both acute and community. Next slide, please. So I know that for everybody attending this session, this likely won't be the first time that you've come across fatigue, and that you know how at times, how complex and challenging it can be. So let's start though, by asking, what is fatigue? We all know the word, it gets used in lots of different contexts, but what do we really mean by it here? For some, they might think of it as extreme tiredness, or perhaps think mainly about the physical aspects. But we now know from research that it's a multidimensional symptom with physical or body, cognitive, thinking, and emotional feeling components. Because of this, it's clear that there is no one-size-fits-all when it comes to what fatigue looks like, especially in children and young people who can often have highly variable levels of energy. They might look lively one moment and not look very fatigued, and then crash moments later. They might go to that physio session, practice doing steps, and later that day not quite remember what they need to do to get ready for bed. That night they might sleep badly, have pain or sickness, and the next day in the same session they're unable to do those same steps. And in this example we see both the physical and the cognitive elements of fatigue. Often, however, the physical part, i.e. not doing the steps the next day, much easier to comprehend, both for the child and those supporting them. The understanding that there's a connection between energy exertion earlier on in the day and an inability to remember in that moment how to carry out a usual bedtime routine, however, harder to connect. And these everyday routines can often feel really complex and challenging when living with such a fluctuating nature of something as fatigue. And therefore, it can be really hard to know how best to support. Next slide, please. So let's just pause and do a quick activity together to bring in insight and learning from your own experiences. Think about your child, or a child you know who struggled with fatigue-related issues, and ask yourself, considering the three elements, physical, emotional, and cognitive, what does fatigue look like for them? How did it show up? When? And in what situations? For some children, it can primarily be thinking that drains their spoons, so questions for them can be hard. For others, it can be emotional. When they feel pressure or stress, this can then lead to physical spoon depletion, but the real culprit and drain on their resource was the stress itself. These are powerful building blocks, this reflection, in developing your toolkit and ensuring it stays useful, helpful as your child continues to develop. And remember, this is a skill and one that we keep building. So for now, don't focus on what you did, but simply continue to build on the understanding of what this looked like through these reflections. And please do share in the chat anything you're happy to, so that we can learn from each other. Sorry, I'm just checking with the right slides going on.
You have more session. You have more time.
Yes, thank you. I'm just checking you're sharing the correct slides.
Okay, Vicky, can somebody share Jo's slides, please? I think she has a number of slides to go. What slide are you on, Jo?
We are currently on a yellow background of a quickfire activity.
Oh. I'm very sorry, everybody. There seems to have been some technical issues beyond our control. I've been asked just to reintroduce Jo and her session. So Joanna is going to speak to you about the Spoonie Kids Fatigue Project. And Joanna is a specialist occupational therapist at Sheffield Children's NHS Trust in the United Kingdom. Thank you, Jo. Go ahead now.
Thanks ever so much. Hello, everybody. Thanks for being here. My name's Jo. Next slide, please. Introduction. Spoonie Kids draws on spoon theory, which uses spoons as a metaphor for an amount of energy that can be saved or spent on different tasks. It was inspired whilst working within an acute oncology setting with an 8-year-old undergoing treatment for neuroblastoma, and co-produced with children, young people, and families with lived experience. The overall aim of today's session is to create a space that allows opportunity to further develop understanding of the nature of fatigue, to support the child at the centre to live their best life, and importantly, to help better manage as a family. The key points as shown on this slide will be covered in the presentation today. And this approach is now being used in over 20 NHS trusts across the UK and internationally, within acquired brain injury and oncology settings, amongst other acute and community settings. Next slide, please. Now, I know that for everybody attending here, this won't be the first time you've come across the word fatigue, or perhaps that you know how at times complex and challenging it can be. But let's start together by asking, what is fatigue? We all know the word. It gets used in lots of different contexts. But what do we really mean by it here? For some, they might think of it as extreme tiredness, or perhaps mainly the physical aspects. But we know from research that it's a multi-dimensional symptom, with physical or body, cognitive, thinking, and emotional or feeling components. And because of this, it's clear there is no one size fits all when it comes to what fatigue looks like, especially in children and young people who often have highly varying energy levels anyway. They might be lively one moment and not look very fatigued, then crash moments later. They might go to that physio session, practice doing those steps, and later that day not quite remember what they need to do to get ready for bed. That night they might sleep badly, have pain or sickness, and the next day, in the same session, they're unable to do those same steps. In this example, we see both the physical and the cognitive elements. Often, however, the physical part, i.e. not doing the steps the next day, much easier to understand, both for the child but also givers. The understanding that there is a connection between the physical exertion earlier in the day and later an inability to remember how to carry out their usual bedtime routine, however, at times harder to connect. And so these everyday routines can often feel quite complex and challenging when living with such fluctuating nature as that of fatigue. Next slide, please. So let's pause and do a quick activity together to bring in our insight and learning from your own experiences. Think about your child or a child you know who struggled with fatigue-related issues, and ask yourself, considering these three elements, physical, emotional, and cognitive, what does fatigue look like for them? Try to make up a pie chart in your mind of each part. How did it show up? When? And in what circumstances? For some, it can primarily be the thinking spoons that drain them. So for those children, questions can be hard. For others, it can be emotional. When they feel pressure or stress, this can then lead to physical spoon depletion, but the real culprit and drain of their resource was the stress itself. These reflections, this thinking, are powerful building blocks in developing your toolkit and ensuring it stays useful, helpful as your child continues to develop. Remember, this is a skill, one we build and we keep building. So for now, don't focus on what you did or what happened next, but simply continue to build on this understanding. And please do share in the chat anything you're happy to, so that we can build from this shared learning. And think not just about the what, how it showed up, but so what? How does what you've brought to mind so far affect both everyday activities, either the things they want and need to do, but also, and more importantly, their sense of self, their confidence, their efficacy, their connection to life and those around them? How does it affect you? Please know there are no right or wrong answers here. This learning you're doing, hold it, keep it with you. It will help with the next stages. Next slide, please. There are 4 stages to the Spoonie Kids process, and each one leads to the next. Thus, today we will mostly be looking at stage 1, developing our understanding of fatigue and how it works. Next slide, please. So one of the first and most important things to do is to develop this shared base of understanding, both with the child and everyone involved. And the terminology we will use has been adapted from spoon theory, created originally by Christine Miserandino. A spoon is a metaphor or a code word for an amount of energy. Think of it as a currency that can be saved or spent. It is a purposeful language, tangible and concrete, for young people and families to learn both how to express and better understand the impact that varying levels of fatigue can have on their lives. Spoons offers a simple yet powerful analogy that enables children to be heard and understood. So why spoons and not another of the analogies that we see used in interventions like the battery or the fuel tank? Because spoons is the only term quickly growing to be the universal term used within the adult world, developed through lived experience. And you hear it now in gyms, universities, leisure centres. There are Twitter handles, forums, #Spoonie Solidarity. You see people wearing the badges with pride. And so when we start with this terminology in children's services, we can feel safe to know that this strategy takes a life course approach. Next slide, please. So although this theory sounds simple, the practice takes some consideration. We might start by introducing the concept and asking, so how many spoons do we have today? Explaining broadly that a well child usually has easily enough spoons for their day and can find more if they need it. But in comparison, a spoonie needs to plan, pace, and prioritize, realizing that there isn't that seemingly limitless amount that there perhaps once was. It varies from day to day. One day a child might wake up and feel it's a good day for them. They might get out of bed, have breakfast, clean their teeth, and still feel like they've got enough spoons to have a shower and go to school. The next day, it could feel like just getting out of bed takes all the spoons they have. Each day is different. And for some, seemingly small things can have a big cost in spoons. A lack of fresh air in a room, bright white strip lights, might make that doctor's appointment cost, say, 4 spoons. Whereas if you'd had the consultation remotely, it would have cost, say, 2. 2 precious spoons that could perhaps be spent later on playing with their friends. It can be difficult for a spoonie kid to take part in social events when every spoonful of energy must be saved first for the essential tasks of life. It becomes clear then that it's a very generous thing to gift a spoon. It shows care, trust, and value in those friendships. Next slide, please. So we touch now on stage 2. What does it look like for your child? And I would encourage you later on following this presentation to really take your time here. Play detective and begin noting things and identifying what impacts your child's fatigue. This is where the resources within stage 2, typical day diaries, can be really helpful to capture what this looks like for your child in an overall picture, because it is so individual and never without the context of life. And so to develop and see these skills and what challenges come up is one of the most powerful tools itself within the toolkit. There is no quick fix, we know that. It will take time. But the more we put in, the more we start to enjoy the process of looking and figuring out, the more we actually start to notice that we already have tools, effective tools in our toolkit. And maybe we can see ways to bring in new ones or better use the ones we already have. Next slide, please. So how to better listen to the body's signs. Have a look at this image you see here. This path, life's path, and the warning signs of a cliff edge being an analogy of the busts that can happen when we overdo it and haven't yet learnt the ways the body shows us before we hit this cliff edge. As you see in the image here for this little boy, by the time he got to the edge, he just felt awful. And he didn't have any words to describe it, just felt awful. But through the stages, through observation, he slowly learned that there were signs. His body feeling like the air was made of mud. It's harder to understand simple questions sometimes or find words to answer. Sounds, bright lights, normally not a problem, suddenly they were hard to handle. And then later, through further reflection, his heart was beating a little faster. He felt a little more irritable than his usual self. And those times that he just felt awful, the edge of the cliff, well, they started to feel a little less awful and happen a little less often because he knew better how to stay on the path and avoid such hefty busts. Within the resources provided, there are all the worksheets to help support stages 3 for the toolkit and the re-evaluation in stage 4. Next slide, please. So let me share a story of Penny with you. Penny is 4. She lives with a medulloblastoma. Penny loves to play. She loves to dance, make mud pies, but what she really loves is going to nursery Now, following a round of treatment, she was discharged home and she so wanted to go. But fatigue remained a daily challenge for her and her family, resulting in several A&E admissions during the year following. And over a 6-month period, despite all the strategies and support they could find, Penny only managed 3 half days in nursery. So we began with education, first with Penny and her mum, followed by the teachers, classmates, and all those involved. And it didn't take long. Posters went up, shared reflections, and Penny and her support network moved through the Spoonie Kids stages to develop her toolkit. And with this targeted approach that focused on the people around her as much as Penny herself, she quickly learned she didn't need to list a load of symptoms on how bad she was feeling to be heard. She gradually understood that she could go to nursery every week for her if she used her spoon-saving toolkit and was supported to do so. 4 times a week within 3 months, in fact. And mid-playground, Penny was whiz-popping across the monkey bars, flying down the slide, and then, before break was over, she ran over to the teacher and shared, "I've ran out of spoons, Miss Hollywood." And right there, in that small sentence, the crux of it all, she clocked it, the avoidance of a bust. And off she went for 20 minutes downtime, ready to join back in just in time for lunch. Now, these early symptoms identified, the simple, understood language accessible, strategies pre-trialed at home, and her whole world knowing how and what to support her, she learned the skills that allowed her to avoid the busts and live her life to its fullest, maximizing potential. Next slide, please. So in summary, a key aim of this approach is to use a shared language and keep developing our understanding of our children's fatigue to help them better manage and live their best lives. It's a collaborative yet individualized approach, not prescriptive nor rigid. Each journey, each toolkit is as unique as each child and their family. The resources are for navigating this fatigue. Use the worksheets, use the visuals, anything that works for you to make it fun. Learning, instead of a prescriptive process, we're learning instead key elements of how to navigate life, living with fatigue. But we all know there will be times when, despite all this, there comes a moment when somebody just doesn't get it. And so we keep safe that positive sense of self. We praise the effort, the awareness, the trying rather than the outcome, recognizing what bravery it takes in this world to speak their body's needs, those hidden needs. So then that the focus of life can cease to be on what you can't do, but instead on all the other bits, the bits you can do. Next slide, please. As I mentioned, there are resources which are available on request. You can contact me with queries or for private one-to-one work or further training through my email address. Our website is currently under construction, so it's best just to email for now. And stage 1 and its resources has been made available to you with the slides from today. So please do take this away and carry on your learning. Thank you so much for being here today. I hope you found it helpful and interesting and that you will continue to take this learning. Do get in touch if you have any questions. It's been a pleasure speaking with you today.
Thank you very much, Jo. That was a wonderful session, showing us how this project will help children best navigate their life living with fatigue. I'm sorry for the blip with the slides earlier on, but we will have plenty of time for questions at the end. We're now going to move on to the next speakers, who are Dr. Natalie Jakubowski and Dr. Andrea Votovich. So they're going to present on PTSD and anxiety. Over to you, ladies.
Thank you very much.
Wonderful. I'm just looking to get our slides popped up here for you all. There they are.
Wonderful. All right. I'm Andrea Weidowitz, and I'm a psychologist at Nationwide Children's Hospital in Columbus, Ohio, in the United States.
And I'm Natalie Jacobowski, and I am a child psychiatrist and pediatric palliative care physician at Nationwide Children's Hospital in Columbus, Ohio, in the United States as well.
So we're going to spend a little bit of time kind of in a 10,000-foot view talking about anxiety and PTSD. Our goal is really to discuss anxiety and post-traumatic stress symptoms and how they may look in children of different ages, as well as how they may present in parents. We'll also discuss when symptoms may benefit from intervention.
I got excited.
Thank you, Natalie. The pediatric psychosocial preventative health model provides a framework through which we integrate assessment based on social ecology, understanding post-traumatic stress and resilience, and then the factors that really influence adaptation over time. The level of risk suggests the types and intensity of resources or intervention that's required to really support our patients and families. We are using this as part of kind of our discussion to really help differentiate symptoms and points of intervention. As part of psychosocial standards of care, we are assessing for anxiety and distress really on an ongoing basis, recognizing that you and your child are experiencing events and stressors that do put you at an increased risk. So if we look really at the bottom here of this pyramid, the universal group is really kind of describing or really saying like everyone experiences some level of distress, but there is resilience. Next slide, Natalie. So when we think about universal symptoms or symptoms really commonly seen within this population of children, if we focus first on our early childhood or our toddlers, younger children, some symptoms we commonly seen that are pretty universal is some tearful, kiddos crying, the occasional tantrum, which we expect, right, developmentally within this developmental period. Clinging to caregivers, really, seeking out support and comfort from parents or caregivers. If we think about our school-aged kiddos, again, we expect some tears, we expect crying, avoidance of a task. I think about this really here is sometimes stalling, right? Can I have 5 more fruit snacks before I get my central line accessed or before I have to take my medicine? We start to see more expression of worries or concerns. So, you might hear your kiddo saying, I'm really scared to do this, or I don't want to do this. And then difficulty sleeping, worrying, or irritability days before, coming to the clinic or the hospital. Again, really just kind of watching that anxiety build before the events that may happen. Next slide. If we look at the top 2 tiers here in this psychosocial preventative health model, we're now focused on more of the elevated stress or the severe escalating distress. This is when intervention is beneficial. So as parents, I think the take home here is really when you notice your child is not acting like your child, that is really when these top 2 tiers or when symptoms within these top 2 tiers is kind of the point to think of, when things just don't seem like your kiddo's baseline. Next slide. So if you look at some symptoms or some examples of symptoms, so again, within our early childhood kiddos, again, changes to baseline behavior, excessive clinginess, excessive tantrums, not wanting to play, not wanting to engage in really desired activities, not really redirectable back to a preferred activity, difficulty with separation. Something I see commonly in an example would be, when you're at home in a safe space and your kiddo won't let you walk out of the kitchen, or they really won't let you leave kind of their sight. For our school-aged kiddos, again, changes to baseline behavior is another, big marker for us to really think about. Avoidance is a big one too. I think about this as difficulty getting in and out of the car, won't participate, in cares, kind of guarding our bodies, for not allowing our medical providers to access the central line. Difficulties with sleep is another, I think, important symptom to point out. Physical symptoms is another thing we start to see within these school-aged kiddos. So stomach aches, headaches, anticipatory nausea. I think anticipatory nausea is a very common symptom. Examples may be feeling nauseous when entering the hospital, or even at the smell of the clinic, or if the hospital has a distinct smell. Often here in Columbus, we hear about how it smells like alcohol or very clean settings, and often that can trigger some anticipatory nausea. Or your kiddo feels nauseous at the sight of a medication or at the sight of their chemo in the infusion bags. Of note, I really, a chronic increase in irritability within kiddos really may be due to anxiety and sometimes not necessarily, other factors. So I just want to point that out, in that it's important to kind of consider and watch for your kiddos. Of note, this is by no means an extensive list of symptoms, as some symptoms can be present, but not really fully a diagnosable disorder. So again, to highlight, your role as a parent or caregiver is really to identify the change that you see in your child, and that's when we'd want you to seek out support. And we know these kiddos and you as caregivers and parents go through a lot, but you know your kiddo best, and that's it's important to point out when you're like, no, this is just not my kiddo. Dr. Jacobowski, on to you.
Thank you, Dr. Horowitz. And as we take that further, as Andrew was saying, we really, as we talk about this with you, is it can be really overwhelming as a parent to try to sort through so many things during treatment, to say the least. But also trying to say, well, what type of diagnosis, or what do I need to do? And so we intentionally are taking it at this 10,000 foot view to talk about where is this level of function and when do I need to ask for more help to figure out what is happening with my child and what resources do I use. So we're coming back to this same model we started with. And at this universal level, the things we think about are that, as Andrea said, we have distress. You can't go through treatment as a child or parent without some symptoms, and we expect that. And in that way, we look to say, if your child is otherwise functioning pretty well at home, at school, with friends, in other domains, and they play and they're able to participate in their necessary medical care, but have moments of distress, they likely fall at this universal level. And we have a lot of supports often built in a lot of places, and different for different programs. Here in the United States, that looks like child life support, therapeutic recreation, chaplaincy, routine psychology or therapy support, and overall psychosocial support from the interdisciplinary team. And then we kind of continue up to look at, what if your child is having a little more trouble? And one of the things that I think is really important in this model, and why I like using this model to discuss, is that you can bump up to one phase and then also bounce back down. You actually don't live in one phase or the other and then stay there, because you might experience some increased symptoms for a time and need intervention. So this second stage of needing maybe some more targeted interventions by psychology or another therapist, maybe psychiatry, which may or may not include medicines. And we'll talk a little more about psychiatry's role, and maybe more focused support from child life. In addition to these things noted below, is that your child maybe is having more heightened symptoms with anxiety or behavior change during hospitalizations that are actually becoming more difficult, but they're doing okay at home. But in the hospital, they're having more distress during that whole time of the hospital stay. Or maybe you notice your child at home is having a hard time that if they hear you talking about anything related to treatments or when giving medication, they're having distress every time that happens. Or they're having sleep trouble, not just the nights before clinic or the hospital, but most nights. And this is a time to maybe bring it up to the team to say, here's what I'm noticing. What might these things be? And they can ask further questions. But it's not just so localized, and you're seeing it show up a little more distressing. And then there are kids who progress to kind of this more clinical symptom trait, higher spot. And again, you don't have to stay at this whole spot, because you may be able to get treatment and bounce down to any of the spots below or up and down at different phases during treatment. And so at this spot, I think of especially where you definitely want to make sure you're getting some more intervention is if symptoms are interfering with functioning. And by functioning for kids, I think about how they're doing at home, how they're doing with friends, how they're doing at school, depending on their age and what those interactions are. Are they doing, when they're doing things they like to do and are playing, are they happy? Are they interacting? And are they struggling to engage with medical care? Not just getting anxious and crying when accessing a port, but they're so worried about not feeling like themselves and feeling weak or having pain that when PT or OT and when those physiotherapy and other people come in the room to work with them, they don't want to do it. And you can't get them to engage, and they used to engage. Or maybe even at the start, they're so overwhelmed and struggle. Or it's the child who worries so much that you're having a hard time helping them shut down those worries, and it's becoming kind of consuming of their energy. And at this point, you want to be using more specific mental health support with psychology or therapists and from psychiatry, which may or may not include medication. And so I want to take a moment to talk a little bit more about psychiatry, because I think, at least for us in the United States, sometimes psychiatry carries a lot of stigma specifically about what it means and when your child is going through so much treatment and people not always knowing what it can offer, is that psychiatrists go through medical training, which gives extra ability to have psychological knowledge and be able to think about medication side effects and medical factors influencing psychological symptoms, and put all of those pieces together to sometimes help with a diagnosis. They have therapy skills to contribute along with others in the mental health field, and to consider the role for medications, which is sometimes really challenging for a lot of families, because having a diagnosis of neuroblastoma, going through cancer treatment, means a lot of medicines that your child has probably never had to take before. But that might mean maybe as needed medications, but sometimes might be a recommendation, especially when you have a lot of spikes of anxiety, for potential as needed a daily medication to help keep that in control for some short period of time, maybe days, maybe weeks, maybe months. It doesn't mean forever, but it's worth sometimes hearing about and learning about. And most of us in psychiatry like to look at that with an open mind, to educate families and help you understand what's happening with your child, to help them return to being themselves in the midst of this treatment.
Switching gears to discuss symptoms in parents, if there is one thing, or maybe multiple things, but one of the most important things, if you hear us say anything in this presentation, it is that almost all parents experience at least one post-traumatic stress symptom in the first 2 to 4 weeks after diagnosis. That's a powerful statement. So almost all of you have probably at least experienced one of the following symptoms: recurrent distressing thoughts or dreams, sleep disturbances, being very hypervigilant, having trouble concentrating, feeling really irritable, maybe some avoidance. I mean, the list is far extensive than that. But again, really highlighting that at least the first 2 to 4 weeks, our parents, you're taking on a lot, and especially within the population of our younger kiddos with neuroblastoma, parents, you're carrying a lot of the burden. Most centers have psychosocial support services available to patients and families. So again, if we think back to this model in the universal group here at the bottom, I mean, this is where we encourage parents and caregivers to really utilize the supports around you. So this may include the chaplain or routine psychology or social work support, psychosocial support from kind of whoever makes up your interdisciplinary team. Family mentors. So a lot of institutions and even this wonderful organization has family mentors. Hospitals. I know our institution has a family mentor program, which is wonderful to connect families with another family that's been going through something very similar, if not the same diagnosis. You know, your family, your friends, your religious communities, your local communities, but really utilizing those supports around you to help you get through the first bit of time, but also just, building a village around you to get through the next steps of your treatment or your child's treatment. Dr. Jakubowski, back to you.
Yes. And so as you kind of notice some increased symptoms, as Dr. Wojewicz was saying, that you can have these symptoms at a mild level, but sometimes even more significant symptoms as parents. And some of those might be that it's hard to stop yourself from continuing to worry about your child. And cancer treatment causes, by nature of what we ask you to do, on the medical side, to be hypervigilant. If they have a fever, a new symptom, please call the clinic. And sometimes that becomes hard to shut off, even when things are reassured. Or you're constantly fearing the next shoe dropping and the next bad thing to come, because you've had a few bad things happen. and it's hard to feel safe and not on edge. Or potentially things like reliving distressing moments. And as we were preparing this, we were talking about the fact that that might be a distressing medical moment, but it might also be something that was distressing because perhaps you saw your child crying, severely distressed, and you couldn't console them well. And it just sticks with your memory because it was such a hard moment. And it comes back and you relive it, or it flashes back to your memory in certain ways. And we keep that broad because those distressing moments are not defined by some certain threshold of medical seriousness, because there's so many as a parent that can occur, or not feeling like your usual self. And at those points, we really encourage being able to think about seeking your own support. And knowing how verbose I was earlier, I'm going to jump us into our next spot, because why it's so important is obviously we want parents to get the support they need for your own sake. But as we all know, I think in a lot of ways, our kids feed upon us and we upon them, because when you see your child anxious and distressed, it causes you more distress and they absorb from you. And when you carry further, it carries into this place where you're both feeding upon each other, and it's hard for you both to reassure each other. And when you're not feeling grounded, it's hard to do that for your child. And why it's actually so beneficial to get your own help, even though it feels like stepping away from your child in need, because you can actually help your child best. And so our takeaway is to briefly really say anxiety and post-traumatic stress symptoms, they're common and they're treatable, and that supports are in place. And when your child is not your child, or you feel not like yourself, please reach out to those resources. And we will look forward to talking more in the question period.
Thank you.
Thank you very much, Dr. Jabowski and Dr. Wojtowicz. I hope I'm pronouncing your names correctly. Just remind the audience to keep your questions coming for the question and answer session at the end. Thank you. It was a really, really interesting session and overview of the psychosocial preventative health model. We're now going to move on to Dr. Marzak, who is going to present on understanding and addressing pediatric medical trauma. Thank you, Megan. Over to you.
Good morning. Thank you. Or afternoon. All right. Okay, wonderful. I'm sorry, one moment while I address my children over here. Sorry. Okay, little parenting adventure over here as I'm traveling now and have my beautiful boys here in the hotel with me. So I'm sure many of the parents can imagine these adventures here. So they promised to be quiet so we can have a nice discussion around pediatric medical trauma. Thank you so much for having me today. So a little bit about me, just so you know where I'm coming from. I'm trained as a pediatric psychologist. I did my undergraduate in a small college here in the United States at that was an undergraduate in neuroscience psychology, and then specialized in clinical psychology and did some fellowship training at the Children's Hospital of Philadelphia. I'm now at University of Kentucky, UCare Healthcare, where I am the acting division chief, and we work with kids with medical conditions broadly, including quite a bit with our oncology team here. I also am a co-author with a book called Afraid of the Doctor. I'm going to talk a little bit about that book today. And then I have a company called the Sally Coping Company as well, where we try to translate some of the ideas from science and evidence into actionable skills that parents and kids can implement together. And then you can see a picture of my beautiful boys there who I've already referenced in this talk. Quick disclosures, I am an author of the Afraid of the Doctor book and a co-inventor and CEO of the Sally Coping Company. And so just to get a sense, I always like to disclose that out there, that there could be financial benefits for either of those tools. We're going to spend a few minutes this morning talking about what medical traumatic stress is, and this really follows on what Natalie and Andrea just shared in the previous presentation. We're going to talk a little bit about how to recognize symptoms and signs, and then try to spend hopefully some time talking about some strategies that you can implement as parents. And then just something to keep in mind too, if you need help for yourself or your child or siblings or anyone in your family, don't be afraid to ask for it. the journey of neuroblastoma is very significant, and it is completely reasonable to ask for help when you need it. So thinking about what medical traumatic stress is, there's a big fancy definition under this definition, which basically says when we think about medical traumatic stress, we think about all the body symptoms that we have in addition to the emotional health reactions that we have. And so thinking kind of like, what are our emotional reactions to scary medical stuff? And one thing to keep in mind as a parent is that the scary medical stuff differs for every kid. So sometimes the things that you would think your child might be afraid of, or that the medical team might think might be scary, kids just roll with it. And they're like, yeah, no big deal. And then other times things that you're like, this doesn't seem like a big deal. Why is my child kind of having a long, big reaction to this? It can be really scary for kids. So just kind of keeping in mind when we think about what is the scary medical stuff, to really think about it from our kiddos' perspectives and from our own perspectives as well. Some common terms that are also used for medical traumatic stress are kind of listed here. Medical anxiety, and I know my colleagues talked a little bit about that. Medical trauma, post-traumatic stress disorder. So if you look in the literature or Googling and trying to sort this out, you might find a number of different terms for this. So my colleagues really shared about a number of kind of signs and symptoms, kind of thinking about when your child is kind of acting out of normal, like things to watch for. Some of the other details on the symptoms that we look at is we look for changes in our kids, and again, trying to keep siblings in mind as well, and then ourselves and other caregivers. But we look for things like withdrawing, starting to be more worried than we would anticipate, that sadness, anger, irritability, any of the kind of those big overall shifts in mood. And then things like in the re-experiencing bucket, sometimes our kids will act out things that they're afraid of in their play, in their art. Some of our kids might have nightmares or bad dreams. For kids, sometimes the bad dreams are not necessarily specific about the trauma, or they can't remember the nature of them, but it can still indicate that they might be having some significant medical anxiety or traumatic stress. We have some of our kiddos that talk about things nonstop. Might have racing thoughts about it. I think, again, thinking about from a parenting perspective as well, what your own experience is with this. Kind of on the flip side, we've got other kids that don't want to think about it all, don't want to talk about it. When I talk to medical teams about what this looked like, I often will say, sometimes we have kids that are like the fake sleepers. If you're in the hospital and the medical team comes in and your child pretends to be asleep, or even for some of our parents, so keeping an eye for yourself, if some of our parents will kind of miss rounds on purpose because it kind of just triggers and is really anxiety provoking. You're afraid you're going to get bad news. And so just trying to avoid facing that as well. Sometimes if you have multiple caregivers, some of these symptoms, if both people are having kind of traumatic stress reaction symptoms, can be really difficult because you might have one person who wants to talk about it all the time, another person who wants to completely avoid it. And so being aware of your own symptoms in yourself, and if you have a partner or grandparents or other folks involved in care, you can, kind of keep in mind that everyone responds differently, and it can also be a trauma reaction that comes out in a different way. This also can be difficult if you're not sure how much information to share with your child and they don't want to hear about it, or, so just something to keep in mind. And then thinking about kind of those physiological body reactions, like that fight or flight, like feeling like, you're frozen, or we have kids that actually do try to physically run away, kick or fighting treatment. Those kinds of things are good to keep an eye on and ask for help if you're seeing some of these from your medical team. One of the things that can be tricky for families and medical teams that like to sort out is there's some other things that can look like traumatic stress symptoms, or that can be hard to sort out. Sometimes if kids are having ongoing pain, some of those symptoms are similar. Then oppositional behaviors as well. Sometimes a child, it's hard to sort out if they're really anxious and having anxiety versus if they're like just not wanting to do it. So sorting out some of those other things. Sleep problems. I know one of my co-presenters right at the beginning talked a little bit about sleep. And we know that sleep problems make everything worse as far as emotional health. So if there are sleep problems, addressing those with your medical team so that you can help sort out, is there other things beyond the sleep? Or if we address the sleep, does some of the other things resolve? So thinking about it for your family, how common is this? We know about 30% of kids with significant injury or illness have traumatic stress symptoms in kind of that early new diagnosis period. And then longer term, it really ranges. Up to 75% of kids can have persistent symptoms. In pediatric oncology, there's some data that suggests 60% of siblings have significant symptoms of medical traumatic stress. So again, keeping in mind the siblings as well. And a fair number of parents also have significant symptoms as well. Well, and so I always like to kind of take a minute to say, the reason that we do this talks is one, to try to educate and say, oh, this is what might be going on for you or your family, or to keep an eye out for it, but to also say you do have some control of how you manage it. So a lot of times in things like neuroblastoma, we don't have control of the medical treatment necessarily. We don't have control on how our bodies respond, how our child responds, but there are things that we can do to try to help you manage the emotional reactions. So I'm going to spend the next few minutes talking about some strategies. And so one of the strategies that my co-author, Melissa, who is a mama of a kiddo with some substantial medical needs, and we wrote this together thinking about how can parents work with their child and empower their child. And so one of the models that we suggest in this book is to think through collecting information. So if you notice a behavior in your child, taking time, learning more about the medical procedure, learning more about what's necessary, what's flexible, what could the medical team do to help, observing, paying attention to, are there different things that make it better or worse, asking for help from the team if you need to. If your child's old enough, maybe choosing some strategies with your child and partnering together. And then you work to kind of help your child through this with the strategy. And then you just repeat that cycle as needed. So if it doesn't work quite right that time, kind of repeat it again and pivot a little bit. So that's a framework that we suggest thinking about when you have a challenge in your child, such as like a needle stick or port access or something, kind of looking through all these different pieces and kind of making a plan together with your child and medical team. There's some other many strategies. I'm going to go through a couple more before the end of the day, but just talking about a little bit here, other ideas of things that you can do as a parent, things like planning ahead, thinking when there are options about time of day for your medical care. Sometimes there's not options, but if there is an option, can you plan ahead to kind of schedule it in a way that makes sense for your child and your family? Really thinking about communication, being consistent in how we kind of reinforce and support our child's positive behaviors. There's a number of different things we can try over time. And if one doesn't work, you kind of pivot and figure out different things work for different parents, different kids, and different families. So talking a little bit about medical play, this can be particularly helpful for kids that are younger or whose kids have more cognitive limitations. This is really thinking about kind of helping your child get used to the medical kind of gear, allowing them for free play. The other thing this can really help with, especially with kids that either have limited communication abilities or are younger, is to create a shared language between yourself and your child. For example, my colleague Melissa and her son work together, and they call needle sticks poke. And they're going to get the poke. And so they created like one word kind of descriptions of different things that he had to go through so that they shared that language with the medical team so that they could all communicate more effectively together. And she did that through medical play. Other things that can be really helpful, especially for younger kids, but even some of our older kids, you can do different schedules. For older kids or kids that have cognitive capacity to manage it, you can write this more as a list or a plan. For kids that might need to see it more, you can do visual schedules. The examples of ones there, you can actually have your child move the different pieces of like when they've completed this part of the day, you can kind of move it along so it can help them walk through. There's also some social stories you can create that can really help your child, again, walk through their specific medical appointment. You might be able to find some templates online as well to how to do this for your child. We've worked with families to even take pictures kind of through their medical care with the permission of their medical team, of course, and then put that and personalize it in a book for their child so that they can really see, this is my doctor, this is registration, this is the room where They examine my, do my vitals. This is the room where we're going to do the, the pokes and kind of work through that way. Another strategy that can be really helpful, particularly as a short-term solution, is distraction. I don't know if many of you have seen the Disney movie Up, where the dog on there, sees the squirrel, and every time he sees a squirrel, he's completely distracted and thrown off track. And so one of the things that can help for kids that are getting kind of painful or scary procedures is if they can get distracted, then it can take away some of that fear. Things to kind of keep in mind as you manage that is we want to watch out for overstimulation. I've definitely been with some families where a child's getting upset, and then you might have one nurse come in and try something, and then a doctor, and then suddenly you've got a room of maybe 6 adults and everyone's talking at once and everyone's trying to calm the child down. So if you plan more ahead and partner with your child, if you can, you might have the lights low, have only one adult talking, and figuring out, okay, what is the distraction technique that will work. The other thing that we want to be careful of is you don't want to use distraction as your only strategy all the time to distract your child away from some of the hard feelings, because we also don't want to promote avoidance. We want to make sure we give our children the chance to express themselves as well. Another strategy that you can use is really kind of using some mindfulness techniques where you think about in the room, and I think my colleagues spoke about at their hospital, sometimes kids get triggered by the alcohol smell, for example. So think about, do you maybe want to have your child chewing gum or smelling a hot chocolate drink, or what can you modify so that it can be a more comforting place? Thinking about for each of the senses, what is your child exposed to and what are you exposed to as a parent? And think about, are there things you want to modify in the room or on the walk over to the clinic, or, what can you set up that might make it more comforting to yourself and your child? I want to just spend a quick minute here talking about when you might want to reach out for more help. So the guidance that I provide for parents, if your child's emotions or your own emotions are getting in the way of what your child needs to do, either for their treatment or other things, if it's interfering with school, if it's interfering with family life, that's a really good indicator. It's time to get some more support. If you just want more support for your child, go for it. Generally we say, therapy can't hurt as long as you find somebody that understands and is good with kids and has worked with kids. Give it a try. If you want more specific parenting strategies to help with your child's challenges, so sometimes it might be about you want to empower yourself to manage your children. Also, if there's any self-harm, harm to others' thoughts or actions, that's definitely a time to reach out to get more help to make sure everybody is safe. Or if others are concerned. Sometimes as caregivers especially, we're just taking care of everyone else and ignoring ourselves. But thinking about if other people are concerned, listening to them and being like, ooh, maybe I do need some more help, or maybe my child does need some more help. So wrapping up to our conclusions here, medical traumatic stress is very, very common. One of the things that I have heard from parents, once we've provided education and shared they're like, oh, I'm not crazy. Oh, this happens to lots of families. So just to kind of normalize, the journey of neuroblastoma and cancers is really, really challenging. So it's okay to have emotional health reactions. We know that recognizing those signs can be a little bit tricky, but there are things that you can do to help your child, and there's also effective therapies that can help. So ask for help if your child needs it. And there is my contact information. There's also a website called healthcaretoolbox.org on there that I just put up. There's some great resources. There's some handouts for parents, workbooks for kids. All those resources are freely downloadable in case anyone is interested in those as well.
Thank you so much, Megan, for that really interesting session on medical trauma. I wonder, could you put in the chat your details of where parents might be able to access your book?
Oh, sure.
And also, there's some questions coming in for you, which we'll put to you at the end of the session. But thank you very much. Really interesting. And now we're going to move over to Dr. Hilary Van Hoord Gatlin, who is going to speak to you about post-traumatic growth. Over to you, Hilary. Sorry, Megan, I should also have thanked Megan's sons for their patience during that session, because I know she said she was traveling with them. So thank you, boys. I think we're just waiting for Hillary to get set up here.
All right, are you guys able to hear me? Excellent.
Yes.
Well, hi, nice to meet everybody here. My name is Dr. Hillary Van Horn Gatlin, and I am a clinical psychologist at Kaiser Permanente, South Sacramento. I was a previous chair of chiefs of behavioral medicine and have recently changed jobs, but I was able to speak with you a couple of years ago. And today I'm going to talk a lot more about post-traumatic growth. And one of the things that I really want to highlight, and I think was important, that has come up through all the different speakers and specialists today, has been that a lot of what you're experiencing is normal. So much of the stress that you're going through, so much that you're experiencing is part of what we would expect. And despite all that hardship, you will also find that you change in ways that you may not have liked, but actually may make you stronger. And that is the concept of post-traumatic growth. So today, as we talk through what to expect, a couple things. The first is that I want to make sure that you understand the various markers of post-traumatic growth. You might already know some of this innately, but to think through what this means for you in your daily lives. And also, and I think perhaps most importantly, thinking about the internal and external impacts on your well-being that might foster post-traumatic growth or take away from it. So the first thing to know is that I have nothing to disclose. I have no other affiliations. And I want to start with this. I actually use this for my dissertation. My dissertation was on post-traumatic growth before it was really a well-known concept. And one of the things that I most love about this, Invictus, if you haven't read it before, is at the end where he says, I am the master of my fate. I am the captain of my soul. And one of the things that we often find with our families and our parents and the children that are going through treatment for neuroblastoma is just the exceptional stress that they're under. And despite that, you'll often find that you are so much stronger, so much more capable, and your perspective is shifted so much that oftentimes people will say, I don't know how you do it. And you're thinking, what are they seeing that I'm not seeing? How are they seeing me as being the strong person? I'm not feeling it myself. But part of what that process is post-traumatic growth. So to think this through, I want us to look at stress and a lot of the psychiatric complexities that come into play with pediatric cancers as family survivorship as opposed to just your child. Oftentimes families will be really and understandably worried about their child who's going through cancer treatment, or perhaps a sibling that is, left behind. But most psychologists in this field will say that we want to look at the family system. We're looking not just at your child who's going through treatment. We're not just looking at the sibling, but we're looking at this from an aspect of family survivorship, no matter where you are in your journey with neuroblastoma. So as we think about this, I want you to ask yourself a few things. The first is this: how has your perspective changed since neuroblastoma became a part of your life? Think about that again. How has your life and your perspective shifted? The second, how has your parenting changed? For better and for worse and for everything in between, how has your parenting changed? How do you connect with others now versus prior to your diagnosis? And I say diagnosis as a family system, again, not as just your child who's going through treatment. And last but not least, where are your priorities different? And I think every person listening right now would say, oh, all of this is different for me. This is a very, very different thing. And what I will tell you is that what we're looking at there is post-traumatic growth. And that doesn't mean that the trauma's over. It doesn't mean that the stress is past. It doesn't mean that this was a great thing. But it means that in all of this, we're also changing and shifting in ways that are good. Hold on a second. Is that better? Okay, I apologize. We had quite a few technological difficulties as we were working this through this morning. So I say this because I want us to remember there is hope. One of my favorite quotations in a recent article was, most research is focused on maladjustment and psychopathology. So when we're looking at pediatric psycho-oncology, we're looking at what goes wrong. And we have to. That's part of our job in making sure that we're taking care of families. But it also overlooks resilience in incredibly difficult scenarios. And so let's talk a little bit about what that looks like. What is resilience? So resilience is healthy or adaptive psychological outcomes. So shifts in who you are, how you look at the world, how you cope over time following something that's been really, really difficult. And so that looks very different in our families who are going through cancer. And so one of the things that we find is that both children and parents will say, I see grace and I see gratitude and I see benefit in places that I previously wouldn't have. They'll also say that I see these places of post-traumatic growth. And when we talk about post-traumatic growth, we're looking at 5 different aspects of post-traumatic growth. And you can have changed and shifted in one of these, 2 of these, or all of these really. First is new opportunities. What's important to you? Have you had a change in career? Have you stopped working and you're at home and you're actually realizing that despite how hard this time has been, it's actually been a really good thing for you that you otherwise wouldn't have done? Changes in relationships with others. What relationships have you lost? What relationships have you gained? Where is there some pain and grief in that loss or disappointment? How has it changed how you just interact with other people? Another one, how do we increase our sense of our awareness of how strong we really are? A lot of times parents will talk about how strong their children have been. And I'll say, well, you are too. And they'll say, oh no, it's an act. But it's both. It gets to be both. And I think that that's one of the things that I think probably every specialist here would say is that you get to have both. It gets to be hard and it gets to be terrible. And in this, you also get to find this inner strength that you may not want to use and may feel exhausting. Another thing that we talk about is a greater appreciation for life. It feels so much more sacred. Or a deepening of your spiritual life. A lot of our families will say that they have a greater sense of religiosity or spirituality following their child's illness. And part of what we're looking at as we look at resilience and this trajectory of post-traumatic growth, which I'm going to show you in a moment, is this stress inoculation theory, which is this idea that moderate stress or a certain amount of stress, which is different for everybody and experienced differently, actually makes us stronger and more able to take on more. Because again, part of it is our perspective has shifted. What's important to us has shifted. What matters to us shifts. Where we put our time and our energy and our heart changes. And so we want to think about what that looks like socially in our relationships, how we address difficulties. How often have you heard from friends, I don't know how you do it? And what you're thinking to yourself is, I have to do it. I don't have a choice. But again, that's that adaptability to changing demands, whether we like it or not. And a lot of families will say, I have a greater sense of optimism. I have a sense of hope about a lot of things that otherwise I would have not felt. So as we move through this, again, this is what we talk about with this trauma trajectory. And I really want to highlight that within any family system, different family members will react differently to this stress. And that goes into a lot of different things. It can be a little bit of personality and temperament. It can be, again, adaptability, how flexible we're able to be. And it could be where we rest our thoughts. And we're going to talk about that in a little bit. And so you'll notice that some people, after a stressor has passed, so we can say that anytime from diagnosis to either remission, from remission to potentially a relapse, or really just from diagnosis and beyond, some families will say, you know what, we try to keep things as normal as possible. I feel like I'm doing pretty well. Other families will say, this was a hit on us. This was really hard. We still have not recovered. We still just are barely getting through. And that's, those kind of that really traumatic impact where we're not finding those other places where we're able to function. And oftentimes that's where we as psychologists spend a lot of our time. And you can have that and also grow in other ways. And I would argue that most of you here have grown in other ways, despite the fact that you may feel that you are just limping along most days. Which is, you have these places where you are stronger, grittier, and more capable than you previously probably saw yourself as being. So again, these are the different aspects of post-traumatic growth. And this was defined by Tedeschi and Calhoun, who were really the first people to start really looking at this closely. So I'm curious, as you look at this, how many of these you can identify with? Not necessarily fully. You don't have to tell me that you've made a full 180 in this place and you're doing significantly better. Of course not. Neuroblastoma is a journey, no matter where you're at on it. And can you give yourself, your family, your child, and I think especially most importantly yourself, credit for what you're doing well, or where you're growing despite maybe wanting to grow? So how do we foster post-traumatic growth? You might be thinking about this for your children, but I want to challenge you to also think about this for yourself. So the first is that it's really important to communicate. The more that we talk, and I think all of my colleagues here would agree, the narrative aspect of just speaking and connecting and sharing and therefore processing what's happening with other people is incredibly important. It lets you get different perspectives. It lets you feel support. It lets you feel connection. And that connection is so important because cancer is by nature a very isolating experience for a family. We also know that that is important as we think about how we look at our outcomes over time, and particularly life after cancer. One example was adolescent and young adult pediatric cancer survivors. And they found that in that specific group, post-traumatic growth was was a benefit to better psychological outcomes long-term. And again, it doesn't mean that they don't have anxiety. It doesn't mean there's some, post-traumatic distress, but it means that they can see that and they can also say, I'm stronger in these ways. I'm better in these ways. I have a different focus on what I spend my time on and what I value and what's important. I see myself as strong, and I still can struggle in these ways. And I want to really, if you remember nothing else, remember that it gets to be both, and we hold them lightly together. And this goes to my next point, which is that it's independent of distress. So you can grow and still really, really have psychosocial issues and challenges, difficulties. You can still see a mental health provider. You can still talk to other people and it be hard, and have these places where you have a stronger sense of self or spirituality or relationship and connection. And finally, we know that survivors who experience significant post-traumatic growth can also be highly distressed at times. They can still feel a lot of anxiety, a lot of depression. And so recognizing both and still seeking out support if you're seeing some of those more difficult symptoms that are getting in the way of what's important to you and what you value are going to be key. So, as most of my families will ask, how do I keep going when I feel stuck? Oftentimes, families with neuroblastoma will say, it feels like we're walking through quicksand. It feels like there's concrete on my feet. I just don't know where to go and I feel stuck. So how do we move forward? Well, the first thing I want to assure all of you is that this, like your cancer journey, is a process. It's not a destination. There's going to be setbacks. And again, going back to our stress inoculation theory, that those setbacks, while hard, also in some ways can truly bolster our well-being and our sense of what we're capable of. Another thing that we talk about a lot is how do we reassign meaning? When things are difficult, it's common to think through the pain. It's common to think about the struggles. It's common to fixate on the people that we're disappointed in. And I think we can all connect with that. And can we reassign meaning to that as well? Can it be painful? Can we be disappointed and say, this is opening up space for me to invest in the relationships that are more important to me? Can we open up a space where rather than personalizing and self-criticizing or focusing on something that's not moving us forward in any meaningful way, can we look instead at what it's also opened us up to? Can we find control and acceptance? We talk a lot about acceptance and commitment therapy, or, kind of radical acceptance, and this concept of this is happening. There are things that I can fight against and I need to. And the things I have no control over, where am I giving my time? Where am I giving my energy? So what can I do? I always say, imagine the worst. And we talk about this with anticipatory anxiety, right? Sometimes it's helpful to go with the worst case scenario because we think it's going to prepare us. And it does to a certain point. But if it's getting in the way of who you want to be, how you want to parent, how you want to feel in relationship with other people, or just your well-being, it's time to really look more closely at that. And finally, I really want to highlight the importance of compassion for yourself and for other people. This is a long, long, long road ahead, no matter where you're at with this. You're not alone. Right now, you're not alone. Tomorrow, you're not alone. And it's going to be difficult. And it's important to have compassion for yourself and other people and recognize when you're bringing the best of yourself, and that when you're not, that's simply an opportunity to forgive yourself, to seek out support and connection, and again, grow. So be patient. So if I leave you with nothing else today, a couple thoughts to think about. Who is your network? Who are your people? Are they what you need right now? Secondly, what are you struggling with? Beyond the obvious, what are the things you're struggling with? What are those bricks that are weighing you down? And of them, what is it time to make peace with? That control and acceptance, right? So that you free yourself up to what you can do. What do you need and how do you tend to it? Just like you tend to your child. And I think also, what do you need to give yourself more credit for? Oftentimes we're so self-critical and we're so disappointed in ourselves for these little bits and pieces that we feel like if I had just, or I should have, or I could have, those pieces that we play over and over in our mind. Instead, I want you to ask yourself, what have I done well? What do I need to give myself credit for? Think back to all the things that people have said to you about, oh, how strong you are. Or, I don't know how you do it. Go ahead and take that in and let that rest a little bit instead of disregarding it, ignoring it, or putting yourself down. And I think as a parent, the reason that that's so important is that your children learn from what you model. So are you modeling that so that they also have a chance to grow? And finally, just remember that what we water grows. I tell this to my patients all the time, and my teenage patients will always roll their eyes at me, but it's true. I want us to think about this. What we water grows. We're going through incredible hardships. And we're experiencing incredible traumas that most people can't even imagine. And it does not mean that we're doomed. Psychologically, emotionally, socially. So where are we putting our time? Where are we putting our energy? When we have those moments, are we doing things that help us continue to be the parent that we want to be, the person that we want to be? Are we giving ourselves space to think forward? And when we are looking back, and oftentimes with regret, can we challenge ourselves to say, what am I watering here when I think about this? Is this serving me in some way? Is this doing something for myself, for my family, for my child that is meaningful today and tomorrow? The answer may be no. And if the answer is no and you have a really hard time letting go, it's a great time to reach out to a specialist, a mental health provider, and take a closer look at that. Make sure that you're freeing up space for yourself and those around you. And so in conclusion, I really want to ask everybody to think through, how do we hold both the challenges and those changes gently for yourself and other people? You know, unfortunately, cancer requires an incredible amount of flexibility. And when we're under stress, none of us want to be flexible. And so how do we seek out support that's going to get us there, or simply remind ourselves when we're feeling that way? And last but not least, how do we use compassion and communication for ourselves and other people to build those relationships? And again, just think about just kind of shoring up, you know, our bone structure as we go through this. And so I want to thank everybody, and I'm going to look at the chat now. So my first question, Laura, was, what would you say to a parent who's worried that post-traumatic growth might be beneficial, but they may be worrying about this moving forward and leaving their child behind? That's a great question. I get asked that question a lot. And I will say, once again, it's both. It is always both things. And so as we look at that, we want to look at, how do we take care of ourselves? How do I hold both and say, this was really hard, this was really challenging, really difficult, I'm still struggling, and I'm stronger in those ways. And at the same time, recognizing that those strengths are what are going to help us with our child, with our family, with the things that we need to do to be in our best space. And then the other comment was, post-traumatic growth needs more recognition and awareness. It's an amazing thing when you have it. What can we do to help others who are struggling? So I always say, again, I think modeling is one of the best things that you can do, as opposed to preaching, prescribing, or recommending. And I think we also want to remember that we can't fight feelings with facts. And so what that means is that when we see somebody who's struggling, we're present for them, we're supportive of them, and we're recognizing our own boundaries. So when that's starting to impact ourselves and our own well-being. And I think that that's a really hard time and thing to consider for our families with cancer, because there's a lot of guilt that comes with feeling like some families are moving on and some families aren't. And so again, it's that delicate balance of looking through and being supportive, but also recognizing what it's taking from you. And again, how do we model it? And I think inviting, I think oftentimes if we're doing something, saying, you know, I did this thing and it was really powerful for me. I don't know if it would be as powerful for you, but I want to invite you if you're interested. You know, sometimes making those recommendations and just leaving that as opposed to pushing it can be very helpful.
Thank you, Hilary. Could I interrupt there?
Please.
And yeah, sorry, thank you very much. That's a really, really excellent session. And I think the message is, you know, how can we have more compassion for ourselves to move forward and look back? And it was a really, really great a description and presentation on an explanation of what post-traumatic growth really means. So we probably will have more questions at the end for you, but I think looking at the time, we'd just like to move on now to our next session, which is being presented by Dr. Mairead Brennan and is entitled Putting the Pieces Back Together, and this is after a childhood cancer diagnosis. So very welcome, and over to you, Mairead.
Thank you, Mary Claire. Lovely to be with you all here today from Galway in the west of Ireland. I am a clinical psychologist based here in Cancer Care West, which is a community-based support centre for those affected by cancer here in the West. And I've developed a children and family service over the last few years. And I suppose also as part of my work more recently, I'm here to represent Childhood Cancer Ireland, of which Mary Claire, our moderator, is the director of the service. And just a little bit about Childhood Cancer Ireland. It was established 10 years ago, and it's a national parent and support survivor-led charity. We provide practical and emotional support for families, and we campaign for better support and services for families and survivors. Childhood Cancer Ireland offers a full range of supports, I suppose, looking at the existing needs and known gap in needs in services here in Ireland, and looking to fill those needs, but also to campaign at a national level for those needs to be met for families. So some of the supports that are offered within the service are parent peer-to-peer support program, a nationwide play therapy and parental advice program, a Beads of Courage and sibling program, supporting parents, survivors and clinicians participating in national and international conferences and events, or Gold Ribbon Conversations, which is our podcast that uses the power of conversation to explore and increase awareness of childhood cancer, educational webinars, self-advocacy workshops for parents and adults and adolescents and young adults here in Ireland, refurbishment of paediatric oncology rooms and treatment rooms across the country. And I suppose with that, striving to find new and more supports to meet the needs of families. Our parent workshop has been developed and run nationwide in 2023, with more development and services to be rolled out next year. So onwards and upwards. So for today, for this session, I want to explore the impact of childhood cancer diagnosis on the whole family unit and how families adjust and adapt with a focus on helpful strategies and the importance of self-care and peer support. And I know it has been the threads that have run through all the wonderful talks here this afternoon. And so hopefully even some of this will be consolidated in this talk. So takeaways from this presentation is that normalizing of the emotional experience of families, because I think often, one thing that we can do is almost that judgment that someone talked about earlier around what's wrong with me? Why am I this way? And we almost get caught up in that trying to think about it or rationalize it rather than experiencing and understanding the normality of the emotional experience that you're having as a family. Also, you want to highlight your existing resilience, those things that you have in place that maybe you haven't paid attention to or recognized as your coping strategies. And maybe some that haven't been in place for a while, but you want to bring them back on board. And also maybe sharing more useful strategies that might help also. And one that is always dear to my heart is the importance of self-care for a parent. So to look forward, I think it is important to also look back. And I often hear of parents talking about trying to figure out what has happened or where they go from here. And it almost feels like a tornado that's coming through your house. And at that time that we're in the middle of a tornado, it's not that we can possibly even think or even emotionally experience it. We're actually just kicking into survival mode, where our stress response is activated and we're moving and acting, trying to stay going through the experience. And it's only afterwards, maybe, that we have time to even emotionally experience what has happened and to adjust and adapt to the experience. And sometimes you're looking at maybe when is the next tornado arriving, or maybe if you've experienced a recurrence or progression within your family, that it feels that the tornado has never left and you're trying to live as well as can be within that experience. In treatment, it's a whole family experience, as we know. Each of the other speakers has already spoken to that. That's the parent aspect of all those maybe emotional and psychological and physical experience that they're having, that may be presenting with symptoms, anxiety or depression or post-traumatic stress response. So it can be something that impacts you at your own level. It also can impact siblings, and we see a lot of research in the last few years around this. How maybe during the experience, the siblings, the focus is naturally on the patient, but the siblings are also across many of their domains. Research would tell us that across each of their settings, from school to home, through peers, that it has had an impact on them. And up to 63% of siblings can have adjustment difficulties to the cancer diagnosis and treatment of their sibling. We also know that they experience a whole range of emotions, not only worry for their sibling, but maybe also some level of jealousy around the attention that's given to their sibling. Not that they don't understand it, but they're missing maybe the attention or the way that their family has been and the impact on that from their pediatrics perspective. We also find that parents maybe are challenged in their parenting approach, having a different parenting approach maybe for the patient than for siblings, and how maybe that causes conflict for siblings and for them to find it difficult to understand. And maybe also at times for parents to knowing that their parenting approach to the patient has changed, trying to find a balance so that there is some level of feeling that they are, and the word that comes to mind and is often used is, I don't want to overindulge them. I don't want to maybe set them up that they have this expectation around the parenting approach that I'm using right now. So they really have, parents have a conflict around that, and how maybe they feel that they don't have the confidence around which approach to use at a particular time. I wonder if any of you recognize this in yourselves, that idea of the plate spinning, all those different demands that are coming towards you. You have the patient's medical and emotional needs, interacting with the team and all the different medical terminology, other children's needs within the family, financial needs or stressors, work-related demands and how they are supported, and the partnership, how your partnership may be impacted by the diagnosis and the focus on the demands of the family. And I suppose it is with intention that I put self at the bottom of this list, because you may find, and often parents find, that their needs don't ever get met, that they never feel that they have the time or capacity to look after self. And often we hear that maybe even their own medical needs are put to the side at the time, or even their own emotional experience. They're trying to keep all the plates spinning, and they feel that they need to push their own emotional experience to the side. And as we know with lists, and when lists are really, really long, we don't often get to that end of that list, and some of those later items often get missed. And I suppose I'll talk a little bit more to that at the end of the talk, around the fact that the importance of that self-care aspect as well, of looking after self. This is looking directly at parents. So the relationship and how there's stressful issues that are maybe across genders, across parents, but also there's some differences as well. But overall, we will hear that at least 50% of parents find that their partnership has been impacted, because there's not that time to maybe focus on that partnership and that intimacy. And you will see from some of these stressors that are both similar and different across parents, that lack of intimacy is one that comes, that there is quite a difference between fathers and mothers, with fathers having more, seeing that more of a stressor for them, or being away from work as more of a stressor for them, while the mother is feeling more of a helping child's siblings and not being able to be there for them as difficult for them. And we often hear as well, and some of the research would tell us, in that space of not having capacity to maybe strengthen a relationship and have that intimacy, that sexual intimacy may be put to the side. And something that may be of value to you and is impacted, and something that you, if you recognize as something that's impacted, and something that is important for you to come back online with, that there's space given to talking and thinking around this. Finishing treatment is often comes with a range of feelings, and I think it's very important to name that. That if you're finishing treatment, that everyone will may say to you, "Isn't this absolutely amazing? You know, everything is great now. Right now, you must be absolutely excited, and you must be relieved." And I think it's already been spoken to in other talks around that dichotomy, that you can have both feelings. That there you may notice some of those things that have been impacted within the family unit, such as relationship strains. There's uncertainty about the future. There's fear of recurrence, as well as that relief and excitement. And that's normal, and not to feel that you can't be holding both. Some families would say it's almost like a new norm. It's not that you've returned to normal, like other people may say to you, but it is around that new normal, how you as a family unit adapt and adjust and move forward. Sometimes people say it's almost like a roller coaster of different emotions of different times, so each family member feeling it at a different time and experiencing it in a different way. And that's important, that we're patient with each other and recognize that no one's doing it right or wrong. We're all maybe doing it a little differently. Some people would refer to it as falling off a cliff, that they have medical appointments are less often, or maybe that they feel that uncertainty and worry around not being maybe held by the medical team as often as they did. And some would refer to it as living with a shadow, of learning to manage the vigilance that people talked about earlier, how our system is in that hypervigilant state, and how we maybe learn to manage that over time. And also, when treatment ends at a particular time, that we need to maybe look at seeing that as a starting point for recovery of the family, rather than an end point. And that is something that even, at a time where some families are facing into recurrence, are facing into a difficult prognosis, that those moments of recovery, even at a personal level, of having that self-care and taking those moments, are very, very important to almost recharge your battery, or as Joe spoke to, those spoons, how we can recharge those spoons or regain those spoons. And also to name that treatment decisions and how that can be so difficult, especially around different treatments, oncology treatments, but also clinical trials, and how that brings up so many different emotions for us. There's that decision fatigue that's often happening because of all the different decisions that you need to make at that point, where stress levels are so high that our ability to make those decisions are really difficult. We also may face tensions within the family of different people having different opinions or different decision processes, and how we manage that. There also may be that feeling of, how am I going to make the right decision as a parent? Being a good parent can be associated with making the right decision, and how challenging that is in that terrain to be able to choose which one is best for you and your family. I mentioned around different decision-making processes, or different opinions, and maybe sometimes opinions from outside the family or the extended family that are given with the best of intention, but how stressful that can be when you are being maybe bombarded with different clinical trial opportunities, or opinions given by extended family members, and almost that idea of, this is another option. Are you not trying to look for it? how do you feel about it when you're already bombarded with so many decisions to make, and these communications are sometimes very unhelpful, and parents often feel that they are, again, going back to making the right decision for their family. If other people are presenting it, why aren't they thinking about it? Why are they not researching it more? The what ifs, the whys, the regrets. So it can be an absolute roller coaster and very tense and difficult time, and very difficult time to which we make decisions for yourself and your family. But I think it's very important that we really name that idea of making a decision that is right for your family, irrespective of how others' opinions may be coming into the mix. What they say within the research is if we can almost take an attitude of no regrets when you make a decision, which is a very difficult thing to do, but it is around maybe using some of these decision-making processes to help you make a decision at a time that you can say, I made the best decision for my family at a particular time, and to look back at a later stage with regret is unhelpful. And when you have more information at hand at a later stage, it is really a luxury in that it wasn't part of your decision-making process at the time. How could you have known that information if you didn't have it at hand at the time? And so it really is about feeling certain yourself that when I've made this decision, I've made it to the best of my ability with the information and support that I have at hand at this time. So some of the things that can be helpful in that decision-making process is giving time, and that's not always available to you due to the treatment demands or the availability of the clinical trials. But if any time can be given, that is ideal, so that you can have time to think about it, to think about your individual preferences for you and for your family. What are the needs of the family? A decision for one family around a clinical trial might be completely different to another family, and it's to know and respect your individual family's values and needs. Communication, that is clear communication with the team, so that you're making an informed decision for yourself. And obviously time is helpful in that. Clear information from your team, and also feeling that you can go back and you can ask more questions, that you don't feel hurried, that you feel that you've enough information, that you know that even if you have been given an answer and it doesn't feel clear enough for you, or you don't feel certain, that you can go back and ask for more. Support also is very, very important. The support that you need from the team, you need from family, you need maybe from other professional support services, that psychosocial support, maybe through social workers, to help you to maybe to have that, ability and to reduce your stress levels to a place where you can actually make a clear decision for you. And also seeing what part the patient can have according to ability. So really is ability dependent. What level of involvement can they have in making that decision around their treatment and clinical trials? And often parents ask me or have maybe a resistance to engaging in palliative care and thinking that maybe it's not time just yet for us. And I suppose it is important to name that it's not synonymous with end of life. So I often hear families saying, just not yet. But it is really to say that early involvement is key for patients with high-risk cancer diagnosis. So very important, so that you can get the level of support that's important for your family. What it can really do is that it can help you to improve outcomes for symptom management and for quality of life for patients and family members. So it's not that it's either or, that you have cancer-directed care or palliative care, that they go in unison together. And that is about building up that relationship with the team so that they're at hand when you need them. And I suppose just even to lean into the research, that what it tells us is that a lot of times, when 50% of the times that patients and families engage with palliative care, the ideal time to do that is when they still feel that the plan for care is cure. That it doesn't mean that you have to feel that it is entering a new stage of end of life, if it's made available to you, do engage with them and start building a relationship with them. So again, just looking at what's available and what's identified needs in palliative care. And I suppose this is a consolidation of opinions from parents, from patients, and from clinical providers. So from healthcare professionals. Or what are the identified needs for families within palliative care? It is that communication, to get that building up of a rapport, and to being able to be for the team to be available to all members of the family, so everybody's voice is being heard and everybody is being cared for. Symptom management is an important part of that, to be able to even to learn to understand how best to measure and track symptoms for the patient and being able to attend to their needs as they arise. Also, another role of palliative care is around cognitive understanding, helping all members of the family to understand where things are and how everyone is. Because I think often and it's meeting the patient where they're at and meeting every member of the family. No palliative care team is going to introduce a topic that someone is not able to take on board. And I suppose that's the important part of it, is that there is that space for all family members, and that it's taken at the level and need of communication and understanding for each family member. Other needs, such as physical or financial needs, will be addressed to the team as well, and also at helping maintaining relationships, that the role of the palliative care team being the carers and medical carers for the patient. And so relationships as siblings and parents and child relationships can be maintained also. Resilience was spoken about already, and I suppose it really is about that resilience of how we bounce forward, or bounce forward rather than bounce back in terms of our family after university. And a lot of research would say that family resilience is something that we can build together. That's really, really important for us to build together. And some of the things that are under each of these different aspects of family resilience within the oncology setting is that belief system of how maybe we have shared belief systems, that how our spirituality is in unison, or how it supports us as a family, how our outlook might be in unison, and how we share our emotional expression of things that are happening for us as a family. Another aspect of that is communication and problem solving, how we are open and clear in our communication with each other, that we're sharing, that we're journeying together, that it is as a family that we are facing and living and recovering from adversity. Organizational patterns is that flexibility within the family, how we're flexible to each other's needs and respect and understand. We maybe all experience it differently, how with patience and understanding that we support each other irrespective of our different coping styles and our different opinions and emotional expressions. And also what other maybe external supports and resources are available to us, whether it be external supports, both professional and personal, and maybe also some other resources in terms of financial resources can also be helpful. And with our resilience, and you may know some of the aspects of your family, that coping strategies that you have used, and hopefully this has maybe validated some of those along this this talk here this evening. But also looking at, it is never too late. It's planting seeds of looking back with your family. When we spoke about maybe the siblings' experience, when we spoke about your experience as a parent, your experience as a partner, it's about how maybe we can look back at those different things, of things that went well and didn't go well, Because when we're making meaning of adversity as a family and looking at that, open and clear communication, emotional expression, it's looking at how in that time, things that went well for us or things that didn't go well. So that we're leaning into things that work well for us as a family, but also looking at things that didn't go well, so we can look at making repairs for those or bringing those forward or putting new strategies in place that can help us do that. Because I think it's really important that sometimes we feel that we can't look back, that we don't want to bring up create a feeling or create a memory. But what we find is that doesn't happen. We don't create it, we maybe give space to it. It's already there. And so we're giving space to it. So the take-home message would be that when we're communicating, we're looking at visiting and revisiting maybe some of those difficult moments together. And you can see in this picture that they're not looking at each other. As we say, no eyeballing, because it's very difficult to talk and maybe to share how we're feeling if we're looking directly at each other. So really that if we're doing an activity, sometimes they're in the back of the car and you're driving. Sometimes we're going for a walk. Sometimes play can be a very natural way in which us connect our emotions. So it's having that space where you're dipping into what was it like for you. So finding little micro moments where you're planting little seeds and is giving a young person, whether it be the sibling or patient, a space to maybe come back later to how they were feeling or what they were thinking. So it's planting seeds to go, I'm open and available to have these conversations. So you can use prompts like, remember when? Name a feeling such as, and be very honest, I am or was worried or angry or sad. And then ask them, what was it like for you? And sometimes it's about validating. It's not about fixing it, but it's often not about fixing it. And I think sometimes as parents, we go into fixing mode, that if we reveal a difficult feeling, that we need to fix it then to make it better. But really what they want is that space to share how they're feeling. So letting them know that it was very difficult for them. Encourage them by telling them that you're glad that you shared. Highlighting their strengths, the things that went well, because often, as we say, we focus on the things that are not going well, but it's also important to name those things that went well. And then invite further conversation also. So it's maybe saying something like, that was really difficult for you. I'm glad that you shared, and I'm happy for us to chat again anytime. You're welcome to bring it up, but not to fix it, go into fixing mode. And also to know your own capacity. Maybe you're not able to have those conversations. Maybe it's somebody else is having those conversations. So self-care is about caring for you. And I think it's a very important thing for us to finish up on. Caring for you so that you can take care of all the family. And if we look back at that analogy around a tornado coming through the house, and the house has been impacted, you as a parent are the foundation of your house and of your family. So caring for you means that caring for everybody else. Back again to the analogy of the tornado, it is a necessary skill that our parasympathetic nervous system, our nervous system is activated. So our sympathetic nervous system, that fight or flight response, kicks into action. And we almost have to learn to rebalance our nervous system, to able to turn back on our parasympathetic nervous system when we have the time or when we have a moment to do so. And that really is a relearning when you've had to be hypervigilant, have to be hypervigilant a lot of the time. And it is about rebalancing our system, and that keeps us in the best space for well-being. If we can recharge our battery so that we can cope well. Self-care, not to put an extra demand on you, but it is maybe about doing small little steps. Because I hear parents say all the time, don't ask me to do any more. I already have all those plates spinning. So know that self-care and the base of self-care are very small changes, little steps of eating well. Am I making sure I'm having breakfast? Am I hydrating? Am I being active? Am I getting out for a walk or some fresh air? Am I getting sleep? Enough sleep? Healthy sleep? Can I go to bed 10 minutes earlier? Can I take naps? How can I make this happen for myself? Just a little bit. Even if I made one little change this week, what would it be? How do you reduce your stress? Is there time for you? And is there time to reach out to others? There's so many supports within your own region. And I suppose it's important for you to maybe know who they are and where they are and to link into them. These can be peer or professional led, individual or group, for all family members. And it may not be therapeutic groups, it may be gentle activity based. And just to know that it can be really helpful in reducing isolation for every member of the family, normalizing the experience, and offering you empowerment by helping you to recognize the coping strategies and capacities that you have, and knowing that the support is there. And I would encourage you all, if you haven't already, to link into local supports, because sometimes it's knowing that they're there and that you may not use them right then, but knowing that they can be available to you at a different time if needed. So again, just to conclude, we explored the impact of a childhood cancer diagnosis in the family unit and how families adjust and adapt with a focus on helpful strategies and the importance of self-care and peer support. So I'm hoping your takeaways from today is normalizing emotional experience for families, highlighting existing resilience and sharing useful strategies, and the importance of self-care and support. Thank you very much, everyone.
Thank you very much, Mairead. I think your image of the man with all the plates spinning is an image that really resonates with our audience. And thank you so much for your advices on, particularly on tips on self-care and how we as parents can cope and manage the new norm, but the importance also of accessing supports that are out there. I think we have a few minutes for questions, and the first one is actually a comment, and it's a comment from a viewer. I felt that there was no time to assimilate one trauma before the next one came along. Nothing can prepare you for that burden, but knowing that there is help out there is fantastic. Would anyone like to comment on that? I see you all nodding your head in agreement.
I mean, I think that is a sentiment shared by many and many of our families. When we talk about trauma and responses and how we naturally respond, we hope that, we have a trauma response and then we start to recover, and then you'd go on with life. But with neuroblastoma, it's like one thing after another after another. And the other thing that's also kind of layered on top of that, I don't think we touched on today, is the rest of life. So the rest of life doesn't stop, and there's other traumas sometimes happening in the rest of life also, and other things that we have to juggle. So I think that is, that's right on target. And one of the reasons that we are trying more and more to integrate psychosocial supports as part of healthcare, mental health is part of health, and really trying to integrate it in.
Thank you, Megan. The next question is addressed to Dr. Hillary. It's a post-traumatic, post-traumatic growth needs more recognition and awareness. It's an amazing thing when you have it. What can we do to help others who are struggling?
Yeah. So, I think amongst all of my fellow professionals here, it's something that we all very much recognize. I think oftentimes in the midst of the chaos and the trauma that families are experiencing, it can feel a little bit like, this is a saying in the US, toxic positivity. And so I think it is one of those things where I really want to encourage families and, really any professionals that are listening to, again, recognize that it's both at the same time. There are ways that we adaptively have to become stronger just to survive. And it is an incredible survival mechanism. And so we want to, for those that we want to support, recognize where they're really struggling, where they're having a really hard time, where they're hurting. And also say, I know how hard this is for you right now. And I want you to know I see all of you. I see how hard you're working to keep it all together. And I love you. I'm proud of you. And I'm here.
Thank you. The next question is again for Megan. Is distraction easier to manage with younger children than older children?
I think it really depends on the kid and the family. I've had some really effective distraction techniques with teenagers and even young adults and even parents themselves. I think the key with our older kids and our older teens and whatnot is to get them on board. So while with a younger kid, you might be able to distract without them really knowing what you're doing, your teenager's going to see right through that. And so to really plan ahead this is a thoughtful strategy that we're going to put into place as a family and figure out with your older child, what is it that you think might work for you, and really get them on board and partner with them. And think about it for yourself too. If you need a distraction, plan ahead and figure out what that could look like for you.
Thanks so much. A question for Dr. Andrea, and it's also relevant for Mairead. It's possibly coming from our perspective in Ireland also. In Nationwide Children's Hospital in Ohio, in practice, how does the team identify the children or families where more intervention is needed? And if so, if once you identify those needs, do you have in place the supports to be able to facilitate the interactions or the support to put in place the supports that are needed?
Great question. We are super fortunate here at Nationwide Children's to actually psychology, social work meet every new family diagnosed with cancer at time of diagnosis. And then we follow through the trajectory of treatment and beyond. So again, that just sets up a nice model that we are continuing to, have ongoing evaluation and assessment of kind of where families are at and be able to provide, whether it's kind of some of those more universal interventions and supports to very targeted interventions if there's specific needs or challenges identified. I think some of the beauty of that too is psychology specifically isn't called in when there's a crisis, right? We have that opportunity to build rapport and really kind of break down the stigma related to sometimes, hey, kiddo's having a really hard time and parents are trying everything in their power, and it's okay. We're already part of the team. We're already involved. You already know us. Let's put our heads together and figure out how to best support kiddo and parents in the moment. And also I think we recognize needs change over time. So I think that's another important and wonderful reason why I think, we love our model here because it just gives us opportunity to kind of, assess the things that have worked and recognize with parents that sometimes, a strategy that worked at initial diagnosis, maybe at relapse doesn't work because now they're 8. But at 2, right, we could distract very easily with Peppa Pig or whatever the case may be. But at 8, we have to get a little more creative. So I think it just lends a nice model for us here.
And I think obviously in Ohio, you're very fortunate to have the numbers and to have the available supports at the hospital. I see Mairead smiling there.
That sounds like a wonderful model. Can we have it? Can you have you? Unfortunately, we don't have the same services available here, but I suppose that's why Childhood Cancer Ireland are here, just to, that is, if you can't get it within the hospital, but and I'm not sure who mentioned, I think it was Megan earlier, I'm not sure who mentioned, that your child. So if you are, and siblings, so if you feel that there is something that you need extra support with, that you reach out for it. And even if it is not available through the team, that you can maybe be signposted from the team, or you can access other supports. And Childhood Cancer Ireland are phenomenal here in Ireland of being able to offer that peer support, but also maybe signposting if more supports are needed. But yes, it is an ongoing challenge for us to be able to keep developing our services here. There is a model of care in place that, will hopefully work towards that over time, but we are in our infancy right now.
Thank you very much, Mairead. And I think you also touched on the importance of empowering parents. And I think as a parent, I always felt that I needed more information all the time. It's not medical information, but we just needed to know, medical information that would suit the particular family, but also information of all the supports and services that are available and how to access them, because every family is different. Every family's socioeconomic situation, where they live in the country, is different. The hospitals they're attending. So no two families, despite even no two families have the same diagnosis, no two families have the same circumstances. So having the information that then they can choose what is relevant or what is appropriate for them, I always felt was very, very important.
Sure.
I'm not sure. I think we need a little direction, because I think the questions need to finish up now, because we're eating into the audience's break. So there are various people have shared their emails. So I presume that they're happy. Presenters are happy for any questions to be passed on to them. And I know Jo had to leave us earlier, and she shared her websites, as did Megan. And I think if you have any other information, if you could put your email, if you're willing to do so, into the chat, so that any questions afterwards can be put to you. Also for the audience, if a session is missed, it is available to watch on demand here on the event platform. So all it remains for me to do is to say how much of an honor it was to moderate this session, to meet you all, and to thank you for your time and for your wonderful presentations. I think that it has been hugely beneficial to everyone on the platform today. The next session after the break is, there are two sessions. One is on the research track. We have advocacy and research, and if you'd like to follow that, if you move over to stream 1 in the left-hand menu, and if you would like to hear continue on the supportive care tract, we have the impact of chemotherapy on hearing, and if you'd like to hear that session, you stay on here on stream 2. So thank you very much from Ireland, a nice sunny autumnal evening here, and wishing you all the best and a fruitful conference for the rest of the evening. Thank you very much. Good night.